Everybody. We'll be now moving on to our next session, which is infection prevention and antimicrobial stewardship. The moderator for this session is going to be Dr. Muralidhar Varma, Professor and Head of IFD, KMC Manipal. Over to you, sir.
Good afternoon, everyone. I hope you had a wonderful session in the morning, right? Completely about the tropical infections. So the afternoon theme will be completely about prevention, right? So I know post-lunch session is difficult for most of you. So what I have done is there are few lectures and there are a lot of stations. So you have to go to individual station and we will teach you. Fine? And it's more practical thing. I am not going to bore you with all the theory. I will try to build up the concepts, right? And what we have done to understand. Because preventive science is little bit different than therapeutic science. Fine? Can you put on the slide, please? The on ಮಾಡಲಿಕ್ಕೆ Yeah. So in the first section, we will talk about infection control and prevention. So if you look at it, simply called as IPC, that is a term finally the world has recognized. It has two sections for it. One is to prevent, other one is to control. So our fundamental aim is always to prevent rather than control, because control term is one step behind. That means if you can't prevent, you try to contain it in one place, like how we did it in COVID, right? So whenever we take policies or when we plan anything, our first step is always prevention. So I'll start with a case, what we had, means our hospital had, and then we'll build up the whole story. So this was the lady admitted about 2 months back in one of our big ICU, it is called as ICU 2, with refractory seizures, and cause of refractory seizure is autoimmune encephalitis. So she was slowly recovering, but on day 6, she developed high-grade fever and she had a new onset hypotension. So the blood culture was sent as a part of investigations to find out the cause of fever. So these are the blood culture report. So both the bottles, we sent 2 bottles, ideally should have been 4. Both were growing Pseudomonas. And bottle B as a default in our hospital always is from the line, because line could be one source, there could be other potential sources. So what is this due to? Is it a hospital acquired infection or is it a part of the same disease? This is a basic doubt. I hope all of you have heard 2 terminologies which are often interchangeable, but we will try to explain they're actually not. One is CRBSI, other one is CLEP-C. Right? Do you agree that this is the case of CRBSA or CLEP-C? All of you agree or not? In this case, patient got admitted on day 6 or 7 having fever, and both the blood cultures, one from the line and one from periphery, is growing. Same organism. Does it fall into line related infection or not? How many of you will raise the hands? I don't know. Online, I don't know. I can't directly talk to them. Do you agree? Okay. Others, they're not sure? Okay. So what we are going to do is we'll go through some, using this as a case, we'll try to understand some of the basic principles of infection control and how we understood in our own hospital. If you look at our hospital acquired infections, there are 4 major, these are reportable, that's why we do it in detail. One is central line associated bloodstream infections, ventilatory associated pneumonia, surgical site infection, and catheter associated UTI. I put COTI as the last because in our hospital we don't have much COTI, right? For us major problems are CLEP-C and VAPS. So to look after all this, we have something called Hospital Infection Control Committee, right? We were one of the first few university hospitals to have Hospital Infection Committee way back in 2002 when I just joined as faculty, right? So how it works is we have an organization, we have HICC, and we parallelly run with nurses, right? Right now I am the chairman, and Dr. Barnini, who is going to take one station, is a infection control officer. And we have about 8 infection control nurses who sort of do lot of work. One of the important work they do is surveillance, getting the data, how many have highs, vaccination, there are a lot of things we do. So it's a common myth that infection control or the work of HICC is only to do prevention of high. No, that is only small part of our job. We actually, one of our major job is to protect all the healthcare workers. So almost on monthly basis, I send data to medical superintendent office and ask them how many masks we need. We make sure the basic things like gloves, mask, all the basic things are enough stock. So we look after all those things. Vaccination in some of the nurses, we encourage people. Then needle stick injuries is a very important part. You will have one station on it, how to do prevention for it. Right? These are all part of our job. Apart from that, the facility safety is also our job. So we look at air quality, food you eat in the canteens, water you drink. So we understand the data and we act on it. Whenever there's a small outbreak, we sort of do an outbreak investigation and try to find out how we can reduce it. Like a lot of PGs I keep hearing they had diarrhea, they had cough. So we work on it as we get data and see how we can mitigate it. So infection control is not about only preventing infections in the hospital. We do beyond that. And healthcare professionals who work, including everybody, not doctors alone, are part of our job. So what is the principle behind, what is the single principle behind all this prevention, right? As you know, like on yesterday, our petrol prices have gone up by 3 rupees. Karnataka has gone up. That it's just like how we say chain. Okay, everything has a cycle, right? A chain is only as strong as its weakest link. See, something happening 1,000 kilometers away is still affecting us, which have no relation, like, right? Gulf of Hormuz. And there are 2 more gulfs, like one is in Malacca, which is near Malaysia, and there is one more near Somalia and all, okay? Right now that is not affected. If that is affected, our petrol prices will go up even further, right? Just like that. So if I want to prevent any infection in the hospital, we look at every part of the chain. As I said, I'm trying to give an example of central line infection and trying to connect you, right? So if there is an infectious agent, how does it cause line-related infection? What is the whole chain? That is our understanding. I'll show you how we understood the human mentality in it. So when we create a policy for it or intervene, we actually don't look at one point. We try to cut the chain at every possible way, right? From the portal of exit, mode of transmission, susceptible host, etc. Right? That will be our principle. But being the enormity of our hospital, we are 2,300 odd bedded, it's not possible for me to have to do for every patient. I can't do it. I need to allocate my resources, and we don't have that many manpower or resources to do it, because infection control we do it apart from my clinical work, and we have about 8 nurses for 2,000. The ratio is not great. So what we do is we focus primarily on the high risk areas. We don't focus too much on the wards and OPD. As we get information, we work on it. But there's always continuous focus on the ICUs and OTs. So before we jump into and find out how this infection spread, as I said in the first case, there are 2 things which were confusing. One is CRBSI, other one is Klebsiella. They're actually not the same, because these are, some of them are operational definitions. Like for example, CRBSI is primarily a clinical definition, whether I should remove the line or whether I should treat that line related infection, etc. So this definition is an inclusion definition. That means I have to prove that line is the only source of that bacteremia. The reason is very simple. When you draw blood from the line, if the blood is infected, it will come through the line and you feel line is infected, right? So there are the clear-cut definitions for it. Like if you remove the catheter and send the tip, that should be positive, or differential time of positivity. If you go to the lab today, they will show you about the blood culture. The time when the line from here versus from the peripheral blood, what is the time difference, right? usually the time taken is 2 hours, 120 minutes. If line grows faster than the peripheral blood, then we know this is the source because the burden here is much higher. The second one is quantitative blood culture. Quantitatively we can measure and say, right? So these are some of the methods. But what we do for surveillance is not this, because this is not possible for every patient, right? So we use a definition for surveillance, CLAPSI, right? This is an exclusion criteria. So any patient, right, if you think all other causes are ruled out, then it becomes a CLAPSI. We need not prove that line alone is the source, right? So first most criteria is patient should have a line. It should cross more than 48 hours. It's not 2 days, it's 48 hours, right? And blood culture should be drawn after that. Both of them should be positive, okay? And no other cause has to be found out. So when I say our hospital rates of line infection, I am talking about this definition. So we do in infection control this. When I go as a clinician, I use CLAPSI. Suppose I want to publish a paper on what are the organisms, etc. I will use CLAPSI as my definition, CRBS as my definition. You got the fundamental difference, no? So in infection control, we want to know whether lines are become contaminated, because if they are getting contaminated, that means there is a breach in infection control. Okay? Whereas if I am a clinician, I want to know big decision. Shall I remove the line? Shall I put a new one? I will use CRBSI. Okay? Our lab is equipped to do it. And there is a way to calculate CLAPSI. Okay? Everything, all the 4 parameters which I told, we always calculate for 1000 days. So in this it will be 1000 center line days. So very simple. We look at number of CLAPSI events for each facility. Like for example, ICU 2 if I go, I look at number of CLAPSI for the month, say month of last month's data, I just received it. And then look at total number of center line days. How do we calculate center line days? Every day our nurse will go check how many people in that facility are having center line. They count that. Every day they count and add up for the whole month. Okay? That into 1000 will give us the rates. For example, like we used to have 5. I've just arbitrary number center line days. This is a very arbitrary number. I didn't want to go to the full thing. It's about 2. 2 is a fantastic number. So what is a benchmark to say we are doing a good job? Unfortunately, in India, nobody has worked on it, because in general, preventive science has taken always backseat, because therapeutics do. Like for example, if you see here, most of the companies are therapeutic companies, right? Nobody from prevention will come and do. There's no money in it, right? So benchmarks are very difficult. US has a benchmark, because if you cross that benchmark, that hospital will lose their federal funding, as simple as it is. Right? We don't have national wise, so we use our own previous years and compare it. There is published data from AIMS, and we have made a consortium of infection preventionists and did it, but they are not very standard. Now let us go back to CLAPSI and understand why do people get line related infection. If you look at a center line, there are 4 ways by which the line can get infected. One of the most commonest is the skin, right? When it goes in, it gets infected. Second most common, or probably first most according to me, is the hubs through which the IV, various hubs are used for IV lines, blood or whatever, blood drawing, etc. Rarely a blood is already having an infection, you put a center line, it will go and sit on the hub, it will go and sit on the tip of the catheter, because any new device in the body, anything foreign, biofilm will form, and biofilm is like a very safe haven for all bacteria, especially like staph, pseudomonas, etc. and rarely contaminated infusion. It is not at all uncommon, some of our IV fluids, drugs being contaminated. We don't look for it. We do have 3-4 documented beyond reasonable doubt outbreaks. Okay, I will not elaborate further, because very few people publish it for various reasons. So about 6 years back, I had a very fundamental question. How did this Acinetobacter and Klebsiella reach the patient's catheter? How do you think it has reached? It cannot jump from air, because that's not an airborne. So how did it reach the catheter? So one of the commonest answer every time I ask my PGs is by hands. But how many of the doctors are actually touching the central line? You are not. How is it reaching then? Right? So where is it coming from? So I came out with a simple formula and tried to understand this. This across all infections. So basically, if you go to an ICU or a ward, there are two things happening. There is a macro environment. This is my own terminology, like where there are a lot of beds, there's a nursing station, there is a washroom with a lot of gram-negative bacteria, and people roam around everywhere here, right? And hand hygiene hardly happens in most places because the documented hand hygiene rates are not at true rates, right? And there is a micro environment where very close, less than a meter, if you go to our ICU, you find a red tape, right? Just about a meter from the bed. That's called micro environment. From micro environment, once they get onto the patient. It could be a ventilator, it could be a catheter, it could be people who are working an IV stand or a Mayo stand, anything. All these are contaminated. They are micro transmission. So what fundamentally happens is, once the macro environment get colonized, because there's so much flow people happening, the micro environment gets colonized. Then the bacteria is just waiting for the portal of entry, get into the patient. About 30% of them will go on to become highs, right? Now, if you look at human body, there are only 4 ways people can get infection. Any infection, either through respiratory system, GI system, either oral or anal, urogenital system, and skin. There are only 4 ways. Any infection, anywhere, let it be community acquired, anything, right? So if somebody is having central line infection, it has to get in through the skin or through the hubs. So then, thanks to Vandana, there's a part of a PhD we looked at, when a patient comes to our ICU or to ward, how long does it get to colonize? There are 2 ways. First 2-3 days, cleaning happens, etc. They're okay. By day 4 or 5, most people in our ICUs get colonized, or they're already colonized from the outside hospital. Or the next slide I'll show you, the decontamination or the disinfection doesn't happen. The beds are already contaminated and you're putting a new patient on it. And once that happens, there's something called colonization pressure. So the bacteria will build up because you're not cleaning it. At a certain threshold, based on human body's immunity, it will become an infection. That is where they'll end up high. I put a model here for a VAP, but the same thing happens for the line. The oral cavity will keep building up. We started doing oral cultures over day 1, day 2. It builds up. At certain threshold, it becomes a VAP. Because there's so much bacteria, it will go down into the lung. And you're giving a nice access by putting a tube, which God has not given us. So then I said, people might say, okay, this is all correct, is it true? I looked at our own data. So now I start looking at, will I control my highs? If I want to control my highs, I have to reduce my colonization. So I looked at my math. So how many cultures are going from ICU? Look at this ICU cultures like respiratory system. About 30% are positive of all the sent cultures. Out of that, about 30% will end up getting highs, right? And about 10% will end up having bacteremia. That's again a clear cut how the science is evolving, right? Ultimately, I need to reduce my colonization rather than infection. If I reduce this, everything comes down, right? There are only 2 ways you can prevent. One is to prevent hand hygiene, which is a Herculean task. Nobody washes hands. Let us be honest about it. You can only conduct one World Hand Day, somebody will dance and all that, forget. Okay, every day I have to remind my PGs, did you wash hands, etc. Then they'll smile as if I'm killing them like that, that look comes, right? I mean, nobody bothers. So it's a very difficult task to do it. And the second thing is, the audit data of hand hygiene is at fault. Okay, that's not a true way of checking because it doesn't check all the 5 movements, etc. The WHO audit tool. The other thing is disinfection, which is nobody bothered about it. Disinfection plays a massive role in prevention of highs. And even now we don't have a good Indian company which manufactures cheap disinfection. So always hospitals try to cut cost, right? So if you look at a central line, how does it get into? There are 2 ways. One is from the skin, right? Extraluminal, what I call. And then who inserts the lines? No nurse will insert, doctors. And that can be prevented by putting a chlorhexidine patch. And the other one is through the hub, right, which is maintenance. So when skin gets contaminated, usually your line-related infections happen very early, like say 4 or 5 days. Beyond 5 days, 7 days, it's usually maintenance problem. That means hubs are getting, so they build up the bacteria over the hubs, and finally as you keep giving injections, you flush through it, right? So then I came out with a model. So how do I prevent this, right? Hand hygiene colonization. So I put a score to myself, how difficult is each of this intervention? Hand hygiene, I scored as 4. I mean, it's impossible to get people moving to do hand hygiene. So I felt there's no point me wasting and barking everybody wash hands. It's waste of my time. The second thing is disinfection. The best part of disinfection is, if you look at hierarchy of all the people who are working in the hospital, if you score them how sincere they are, doctors are the worst. There's no unity, there's hardly people listen, they hardly come for meetings, right? Nurses are scored very high in that. You tell them something, it comes from top, everybody follows, right? Like say if medicine HOD says all of you should attend, 90% don't come. Whereas a nursing director comes and says every nurse of this ward should attend, 99 people will be in that hall. That is a fundamental human behavior I understood between doctors, nurses, housekeeping. Housekeeping, you tell them they're all here. You tell them they're here on time, right? So I started scoring, where do I intervene and do this? Second thing is antiseptic baths, because I want to decolonize the whole body, right? I need to clean. We have a protocol, but it's not optimal because the nurse to bed ratio is not great. They're not giving enough time. And hub disinfection. So you're supposed to clean the hub. So I looked at very simple data. So I looked at a file, all the files who had line-related infection, and looked at how many times a hub was accessed in a day. You will be surprised to know it starts from 18 to 37 times, each hub. So just imagine if every time I access and start cleaning it, how much time I'll spend in cleaning alone, which is humanly not possible, right? You think any human will sit and do that? So that is actually more of theory telling everybody you clean the hub every time. And it's like a hand hygiene nobody follows. Like I keep saying, attendance of undergraduate. It's never going to be 100%, right? Second thing is, can I do something from my without having anybody with me? How do I create a physical barrier? So we came out with some plans. So I used simple principles and came out. So this is the strategies we use. Of course, WAP, we have a different strategy. See, first thing is think local. We are Indians. I don't want to read what Americans are doing because way we behave are different, right? We still have, when I went to US and Europe, we have to literally call a patient party and say, we are waiting for you. Here, if I go to rounds, 10 people are jumping on me, they want to speak to me because they're so we live in a different world. So my logic is think local, not global always for prevention. You can get a drug from there. Second thing is you need both. This is a very classic slogan from Sansu, who was in 4th century BC, before the Christ. Strategies without tactics have slowest road to victory, and tactics without strategy is a noise before defeat. Just like Iran and American, both are stuck now. America is stuck, Iran is also stuck. So you need to have both strategy and also tactics. So I came out with two simple things. One is we use technology, where humans are always flyable, right? Human behavior is very flyable, very difficult to get our PGs doing simple things in life, right? All doctors, I am not saying including me. Second thing is, how do I change the behavior? So I have to adapt to my system, what I am working with. I've been here for more than 30 years, so I know how Manipal works, right? So we came out with two different things. One is for high-risk group patients, extraluminally, how do I prevent? I put high-risk people chlorhexidine gels and also skin baths, right? We went to some cheaper ones where cost comes down, then I have to beg and borrow our medical superintendent. Second thing is extraluminal. I said, what we did is very simple thing. If you go to CSSD, Central Sterile Supply, every item which comes from OT after sterilization is packed by a blue sheet. I don't know how many medicine people have entered OT. They pack by blue sheet. The best part of that sheet is it's sterile and it is water repellent, right? Previously everything was covered by cotton and gauze, which is absorbs everything, which is a worst case scenario. That means you absorb everything and putting into the lumen. So we marked a size and I requested CSSD every day for all the central line people, you give me a pack of 6 or 8. All we instructed nurses is cover it up and change it every day. Second thing we did is the hubs, once they open, they get contaminated. So we got from one company and put a caps which contains alcohol. It lasts 7 days, but we have to change it every time. So every day they change the caps. So when it is not in use, you are knocking off that colonization. Right? Very simple local technology, and then started working on it. Then second thing is, how do I change human behavior? Thanks to me, that technology is evolving fast. You cannot escape in Manipal all the stuff. You have to open your email because so many things about you will be coming in that email. Some instruction about your salary, you have CMA to attend, otherwise you will be marked absent, 10,000 things. So everybody has to open. That is the opportunity I took. I started sending emails. What we did is, moment it crossed, because we understood the threshold of colonization. So we said, every 12th or 13th day, we'll send an email to unit head. Unit heads sometimes are so busy, they don't check. Then what I did is I added first assistant. Somebody will see. Then we put pressure from nursing side and say every time they'll remind, sir, till the 13th day, can we remove it? So we started removing the lines and putting a new one. If you go by evidence, we should not do it, but it works because our systems are different, right? So all the theory correct, rhetoric, correct, theory, correct, he spoke so well. Did it really make a difference, right? So what we started looking at, this is about 6-year data, and 1 year is aberrant, 2020 I won't call it because there's too much COVID. We started dramatically reduced our high rates. Look at our rates now. We dropped almost by 44%. If you look at CLABSI rates, when we started this, it was 7.8 per 1,000 catheter days, now it is 2.1. So I am not a number man. For me, every patient who gets infected is in trouble. So we looked at absolute numbers. We used to have 145 per year. It's not about the denominator. Denominator increased because we have 200 beds extra because of the new block. Even then, our absolute numbers have dramatically fallen. So infection control is all about understanding the whole simple dynamics of transmission, right? So that's important to know about it. Right? So this is how the prevention happens. So first one central line with no CRBSI, then gets colonized, right? You send a blood culture, only blood culture from the central line gets positive, whereas peripheral blood will be negative, right? Then it becomes infected, where the central line will be source, is throwing a bacteria into the blood, and then finally no other source is there, right? Then coming to the management. What is a management? Simple rule in medicine, whenever there is source control. So line has to go, right? So the challenge in line in most literature is what to do if the patient requires it. You replace it, okay? Old time till 1980s and all, they used to do something called change over the wire, which is again not good, but if it is required, I am okay with it. That I will leave it to the critical care or the individual unit. So whenever you have a central line, we should never put a new line with a guide wire, because if you put that, you will get reinfection. But in some systems, probably it works. I am okay with it depending upon the individual patient. Second thing is, how long to give the treatment. It depends on two individual factors. One is what is your bug, and other one is what is a clinical condition. If a patient has hypotension, that means don't compromise, you need 10 to 14 days, right? If patient just had fever, hardly any organ dysfunction, it is not staph, not candida, probably you can get away by less than a week treatment. If it is staph with metastatic lesion or endocarditis, you are looking at 4 to 6 weeks. Staph, none of this, minimum 2 weeks. Candida, similar principle, and keep showing there is no bacteremia. So if you look at consensus statements on how long to treat, there's so many variables like that. So there is no one simple rule. Okay, you treat, antibiotic stewardship, you should not give long. Just remove it and give it for 48 hours, which is wrong. Because the older ones were on the other side. They said everybody requires 14 days. No. If somebody has Acinetobacter, had fever, no hypotension, I'll stop it at 4 to 5 days if the patient is better. But bug makes a lot of difference. So as I said, ultimately it is teamwork. You need to motivate people to do their work regularly. So this is our infection control team. who does fantastic work. They're highly motivated. Of course, I put lot of pressure on them to get my proper data. Every day I send email, I need this, I need that, right? And I also go and check. So in nutshell, preventive science is difficult, but it's very rewarding. And it's very difficult to say that I prevented, because you can't post it something which you have not seen. Right? And I'm not into the social media, but you can't post, I saved a life. I saved a life, but in many ways. But I can't put the number accurately, because these are a number which are calculated. Okay, we see a lot of complex cases in our department, as Nitin has shown in the morning, right? But I would say, why did we reach that point, right? If within our capacity, we should have not gone to that point. Okay. Fine, thank you. Any questions? I'm more than happy to answer. We'll go to the next session, Dr. Vandana. Any questions? Any questions online? You have any laptop? You're connecting this? Okay, fine. So what we will do is, Dr. Vandana will talk about antibiograms, etc. Right? Then we will move on to the stations, right? So we will not have much lectures, and last part again I'll bore you a little bit for 15 minutes. Fine?
Very good afternoon to all of you. I'm a little sad that all of you are in the back seat. Hope it is not so boring. I might ask you questions with your permission. Is that okay? No compulsion, but please try to keep everybody awake. It will help me also to speak something to you. Thank you, Dr. Murali, for the invitation. Cumulative antibiogram. How many of you have heard of this word? How many of you are physicians? How many are micro? Micro, I know. Anybody whom I don't know but micro? Oh, you're micro. Physicians? 1, 2. Medicine. Medicine, yeah. Anyway, good number, 50-50 almost. It's good to see. Have you heard of cumulative antibiogram? No? Okay, that's good. Makes my life easy if you don't know what is cumulative antibiogram. You know antibiotic policy? Policy? Yes. So, before the development of antibiotic policy, am I audible? Before the development of antibiotic policy, there is a bigger procedure which is called as developing a cumulative antibiogram. Okay? It is a prelude to the antibiotic policy. But most of the practicing microbiologists would have done by themselves, so you have to bear with me. Okay? So let us begin with the case management pathway, which all of you are very, very familiar. So this is a case of a 65-year-old female, type 2 diabetes, presents to emergency department with a 3-day history of worsening left-sided flank pain, dysuria, urinary frequency and severe chills. Sounds very familiar, right? All of you work in the emergency department. This is one of the commonest presentations. Temperature was 38, blood pressure 100 by 60, heart rate 110, respiration 24. On initial assessment, she had left costovertebral angle tenderness and mild suprapubic discomfort on palpation. So what do you think it is? What comes to your mind? Pyelonephritis, right? So you ordered some test. WBC was 14,000, serum creat high, little elevated, 1.4. She is diabetic, her HbA1c was 9. Urine analysis showed, microscopy showed 160 pus cells per high power field. CT, abdomen and pelvis was ordered, still awaited. It's on the way. Patient is yet to be shifted. So you would like to start empirical, right? Or you would wait for everything? Would you like to start empirical? Yes. So which one? Injection ciprofloxacin, injection cotrimoxazole, injection piperacillin tazobactam, injection ertapenem, injection meropenem. Which one? You have multiple options. There are multiple options in our menu. Many are there. You can choose any one. Right? Lot of options for you. Do you choose on your own or how? How? What is the basis of your choice? Is it a clinical judgment? You just say yes, at least I will be happy that you are with me. Is it a clinical judgment? Yes. Is it a local antibiotic policy? Yes or no? Yes. Is it a national antibiotic policy? She says no. Some say no, maybe. Yes? Okay. There is no right and wrong answer. It is all for discussion. Is there a scientific society guideline? I don't want anything. I will go by the American Society guidelines, IDSA guidelines, or some guidelines which you know better. Or own experience. I don't want anything. I have seen enough number of cases and I am 60-year-old. I have good experience. I don't need anybody's help. My own experience. Or it could be any other reason also, which you might think of. So let us see. Do you send microbiological investigations? What would you like to send? Urine culture? Blood culture. Okay. All of you agree with the blood culture or only urine culture? Blood culture also. Okay, good. So hospital antibiotic policy says for acute pyelonephritis, as you rightly mentioned, the likely organisms are E. coli, Klebsiella, so many, and first line agent is injection meropenem. This is the hospital policy where you are practicing. Injection meropenem 1 gram 8th hourly. Alternatively, you can also use injection cefoperazone sulbactam plus amikacin. It's an alternative choice is given in the hospital. So definitely you will use either of this based on your clinical judgment, which you know I'm not going to deal with that. Okay? The possibility of complications and so many things are there, the host factors, etc., etc. So now let us see what is the story behind. You have a clinical pathway defined. You have an antibiotic policy with you. There are many reasons, many bases for choosing an antimicrobial therapy, that is an empirical therapy. And you all said yes, clinical judgment as well as the antibiotic policy. So you had a little confusion somewhere, local or national or society guidelines or which one? I think most of you won't go by my own judgment. I do this way only. I hope that is not the case here. So now let us see how that antibiotic policy was developed. Just to show you this slide, I think I will, you know that we have a national surveillance of antimicrobial resistance conducted by ICMR as well as NCDC. We participate in the ICMR participating network. All over India, there are nearly 21, 22 centers which share their data with the ICMR, with the help of which they develop a national resistance portal and a national antibiotic policy. So that is by the Antimicrobial Resistance Network of ICMR. One thing I would like to draw your attention, AMR is highly variable. Antimicrobial resistance information is highly variable. Kerala is different from Kashmir, not only in many things, but also in antimicrobial resistance. Karnataka is different from Chennai, not only geographically, it's also in AMR. There is a geographical and regional variations in antimicrobial resistance. There is hospital to hospital difference. Kasturba hospital resistance in Manipal is different from Kasturba hospital in Mangaluru. Hospital to hospital difference is there. Intra-hospital difference also is there. Certain wards have a particular type of resistance, certain another ward will have a different type of resistance. Why? Because antimicrobial resistance is driven by your local habits. The way you prescribe, not only you, the community level, what is the clinical practice there, and what is the health status there, and what is the hygiene concept there, and the environmental factors there. These are the interlinked features and primarily promoted by the local antibiotic prescription practices. Because you are not the only one who is prescribing in a level 3 or 4 hospital. Everybody is prescribing antibiotics, everywhere, everything, because you see them at the last. When nothing happens in the periphery, they come to you. So antimicrobial resistance is highly variable. Please remember this fact. So to capture this hyperlocal variations, what is created is the local antibiogram. Not the policy, it is the local antibiogram, which refers to the local representation of the resistance. That local is your hospital, not the community, unfortunately, it is the local. So I will try to explain to you what I mentioned. We have 21 regional centers participating in the network. We are also one of them. So this is the data which is presented to ICMR, and ICMR publishes it annually to public domain. This is the sensitivity of E. coli from the urine. Urinary infections, the commonest organism is Escherichia coli. I have just highlighted, you need to see only those. For piperacillin tazobactam, one regional center has 18% susceptibility, while another center has 80%, 80. For cefotaxime, one center has 25% susceptibility, that means 75% resistance. Another has 86% susceptibility. Coming to meropenem, one center is just 26% susceptible for meropenem. Another center has 87% susceptibility. That means it is highly variable, center to center. These are all representing different states. These regional centers happen to be medical colleges coming from different states. So I hope all of you agree that antimicrobial resistance is hyperlocal. So cumulative antibiogram, which is developed to capture these variability at a very small level, it has a system, it has a protocol to develop by Clinical Laboratory Standards Institute. The definition of cumulative antibiogram is, it is the periodic profile of antimicrobial susceptibilities of various organisms isolated from patients within an institution. It could be Kasturba Hospital, it could be Victoria Hospital, it could be hospitals. It is analyzed and presented annually, once in a year, minimum, at least annually. That means you can do more times. Only the first isolate of the first specimen of the patient is taken into this cumulative antibiogram. First isolate of the first specimen of the patient. That means today patient came, his urine is cultured. After 4 days he develops HAP. You collect his ET. You have multiple isolates in the coming days. We don't include them. First isolate of the first specimen of that patient. That means it is close to his original self. So otherwise you will include all the hospital acquired pathogens and you will overinflate the resistance. And only species that have at least 30 isolates tested are included to achieve statistical significance. We don't do cumulative antibiogram with 5 isolates, 10 isolates, rare isolates. No, it should represent a majority, that is for statistical validity. And we include only diagnostic isolates, not the surveillance isolate. You may do survey on a fecal sample, on some anterior nares, or you can do any survey on the patient. But those isolates are not included, only the disease causing pathogens, antibiotic susceptibilities are considered into this. There are different types of antibiogram. One is the routine or the cumulative antibiogram, which aggregates all susceptibility data from a facility over a set period of time. It could be 6 monthly or annually. Another is an enhanced antibiogram, where antibiogram is developed for a particular unit or a facility. For example, oncology patients, nephrology department, gastro-surgery, neurosurgery, etc. If you work for only a neurosurgical hospital, their antibiogram will be exclusively for a neurosurgical infections, like that. Or a syndrome or a site-specific, community-acquired pneumonia antibiogram, community-acquired cystitis antibiogram, community-acquired meningitis antibiogram, like that. That is the enhanced antibiogram. The third one is rarely practiced, that is a rolling antibiogram. You don't have to wait for 1 year. When your hospital has a high load of diagnostics, you get 30 isolates very easily in 6 months or 8 months or 3 months, which is more realistic. You don't have to wait for 1 year. Every 3 monthly or a 6 monthly or a 2 monthly or a monthly, whatever you do. When 30 isolates come, you can keep on developing. So you know what's happening in the last month, last quarter of the year, etc. That's the rolling antibiogram. So now, just to give you an overview how it is developed, you always begin with the sending some clinical samples. Let me take example of a urine culture. You have a patient suspected with UTI. You collect urine sample and send to the laboratory. And laboratory isolates a particular organism. In this case, example is Escherichia coli. This is a antibiotic susceptibility test, right? This is not antibiogram. Agreed? This is a isolates antibiotic susceptibility test. Like that, over the time, many patients, many urine samples, E. coli will be accumulated in the laboratory. So we pool them and then calculate the susceptibility percentage, number of isolates susceptible divided, simple statistics. And then we segregate them just on a sample basis I have shown. All the urine cultures in the wards, the patients who are in the wards that represent less severe infections, while ICU is a more severe infections. And then this is how an antibiogram looks like. So which includes information on the sample, what is the sample indirectly shows that what syndrome it reflects. Okay? The location indicates severe or a very severe or a non-severe, less severe. And the most likely microorganism isolated from that particular clinical specimen. And then the common antibiotics that are useful to manage that infection, then their susceptibility percentage. Okay, so that is nothing but a cumulative antibiogram. For example, in this case, of urine cultures coming from the wards during the year 2025. This represented 2025 antibiogram. So on the left hand side, you see the most likely organisms. The top 5 organisms are listed. Definitely they qualify because they are present in more numbers, more than 30. Okay? So is this an example of cumulative simple antibiogram or an enhanced antibiogram? What do you think? Is it a simple one or an enhanced one? What do you think? Simple? I told you a lot of information. What is, it's coming for representing a syndrome, representing a location. It's not very enhanced, but it is a little above the routine, right? Because this E. coli is coming from the urine. We didn't include E. coli coming from the stool or blood or whatever it is. So it is a almost enhanced antibiogram. So now let us see how to use the antibiogram effectively in your clinical practice. So to summary, the practical uses are like this. They guide the local antimicrobial prescription mostly empirically. Targeted therapy is only based on the susceptibility report of that microorganism. This guides empirical therapy, and it also helps you monitor the resistance trends, how you are evolving with the resistance, and it also indirectly tells what are the antibiotic practices in and around that place, locally, regionally, nationally, supranationally, etc. And this is the prelude for a development of antibiotic policy. Without this, you cannot develop an antibiotic policy. So I will take you through one practical example. So you have this antibiogram with you. This represents isolates from the blood cultures from patients admitted in ward, not the ICU. Less severe infections, not critically ill. And the clinical sample is blood. So the syndrome, something representing bacteremia. Okay? So the most likely organisms are listed on the left hand side. E. coli, Klebsiella, Staphylococcus aureus are the top 3 organisms representing bacteremia in the ward. And their susceptibility percentage, the E. coli from the blood cultures in the year 2025 were susceptible 85% to meropenem, for example. So what are the possible clinical conditions this information is related to? It represents patients in the wards, less critical, but the syndrome is something reflecting to bacteremia. You don't know the source. There are a lot of sources leading to bacteremia. Bacteremia is not a disease. Bacteremia is a condition, right? Bacteremia is led by something else. There is some source somewhere else leading to bacteremia. So this represents that condition. This also represents a possible clinical severity because this is not from ICU. And this shows you most likely organisms, and it will indirectly help you to understand what are the most likely sources. So where could be the likely source of E. coli bacteremia primarily? Urine and gut, right? These are the, it cannot be pneumonia. So like Klebsiella, you understand what could be the possible source So to come second in line, like that, okay. So this information is with you. So now if you have a case like this, 65-year-old male patient, alcoholic liver disease, presents with the high fever, chills, acute breathing difficulty to emergency room, and he is a heavy smoker, but when you examined, not in sepsis, and you are given this antibiogram with you. Chest X-ray showed right upper lobe consolidation. Right? So now, try to attempt this. What is the likely diagnosis? Which is the likely diagnosis? Community acquired pneumonia, okay. Likely complications? Yes, may go into sepsis also because he is alcoholic liver disease, smoker, so many risk factors are there, elderly person. Likely organism? That need not be directed by the antibiogram. You should have the background. What are the likely organism? In this list, Klebsiella, yes, but there are others also. Don't be overwhelmingly dependent on the antibiogram. Of course, Streptococcus pneumoniae should come first, okay, but it is not there here, okay. Let us see. Any other information you need to make a choice of empirical now? I have given you only blood culture results. Do you need anything else? Do you need any other antibiogram now? Will you ask for? From the respiratory. I have given you only blood culture. You would ask for the respiratory cultures antibiogram because the clinical condition what you are dealing is most likely a community acquired pneumonia. Okay. I gave you this respiratory cultures. The top organism in that hospital happened to be Klebsiella pneumoniae, followed by Pseudomonas aeruginosa. But will Pseudomonas come as a first organism here? In that case, definitely no. That patient is not a candidate for Pseudomonas aeruginosa. Acinetobacter baumannii, no, not at all. E. coli, no. Staph aureus, possible, community acquired pneumonia, and Streptococcus pneumoniae here, okay. So you have the list of, if the patient is going in for bacteremia or sepsis, it's most likely Staph aureus or Klebsiella pneumoniae, right, and even pneumococcus. So now the most likely organism in that case, you will see how is the activity in the past year for those organisms. Generally for your reference, we mention green color is any susceptibility more than 90%, yellow is 70 to 90, below 70 is a danger zone. Empirically it may not work. But you see now, most of them are red color only. Okay, maybe in the coming 5 years all will be red and you won't see yellow color also. Okay. So now you are mostly in the Klebsiella is fully red. What is yellow? Only gentamicin. Is it a therapy for community acquired pneumonia? So you should know how to read an antibiogram and not just going by the table that is provided and choose, because gentamicin is not a single drug for community acquired pneumonia. So meropenem susceptibility is only 60%. Only 60%. 60% is not a good coverage, right, as an empirical in that patient who is having multiple risk factors. Okay. So now combining this, just to give you some clues, you may think, should I choose one drug or a two drug? If you saw our antibiotic policy, option 1 was one drug, option 2 were combination of two drugs, right? Two drugs were there. That was for pyelonephritis, cefosulbactam plus amikacin. So, if you use only meropenem, you will cover only 60% of the isolates, 40% are gone. So, can you increase the coverage by adding another drug which has a synergistic or at least additive activity useful in the lung? Okay, not useful in the urine because your case is community acquired pneumonia. So, this table will help you. So, you cannot choose mix and match any drug. So, you will know which drug will be useful in that syndrome, in that organ for those potential organisms. So, the combination can be chosen based on this antibiogram. Okay? Yeah. So, this combination will work until microbiology culture reports arrive. Usually within how many days or hours you will get microbiology? 10 days, 1 week. By 2 days you will get the final, right, with the identification and susceptibility. Till then you have to hold the patient with the information based on the antibiogram and the antibiotic policy, which is developed based on the prior information. So, I will just tell you what are the limitations of these antibiogram. Don't think with the antibiogram you can cover 100% of the patients. Definitely no. You should know the limitations. The development of antibiogram depends on what are your diagnostic stewardship practices. Generally, if your sample quality and the clinical decision to send a culture is very good, the microbiology report also will be very good. Good quality sample will give rise to good quality report. Poor quality sampling will give rise to very poor quality reporting. If you don't collect the respiratory cultures well, contaminants, colonizers will grow. The lab might have reported a colonizer, not a pathogen, but it is already there in the lab repository. It would have been added to the antibiogram. That information may not be of great help to start your empirical therapy. So that is where the colonization and pathogen uncertainty lies when you don't send a good quality sample. And also when we take the microbiological culture reports into the antibiogram, we don't have any system to differentiate community versus healthcare associated infection. Currently the infrastructure is not so robust to develop that kind of a differentiation. So all are into one pool unknowingly. So please remember, empiric antibiotic should not be chosen based on which has the highest percentage of susceptibility. You should not read like this and go for the highest susceptibility. Rather, you should consider patient specific factors to guide your empirical therapy, but you can base your decision based on the previous experience of that hospital's antibiogram. And not every antibiotic is appropriate for every site of infection. So the last lap is something like a quiz for you. After getting introduced to basics of antibiogram, so that information is going towards the development of antibiotic policy locally. So now here is a 54-year-old woman with the neurogenic bladder, frequently visits the hospital with symptoms of UTI. And currently her visit is her 4th visit in the last year. That means this is the 4th time she is presenting with UTI. So now what is the usefulness of your cumulative antibiogram to choose empirical therapy in her? Is it useful or not useful? What do you think? She is a case of recurrent UTI. frequently visits. So will you base your empirical therapy looking at the antibiotic policy or antibiogram or anything else? Would you base your empirical on the antibiogram? No. Okay. Thank you so much for that answer. Okay. So you can't, that is the limitation because she is having a high risk for MDR organism. She is no more a community infection. So she doesn't fit anywhere in your cumulative antibiogram. So you will go by your clinical decision to choose antibiotics on her. Okay. So these are the limitations where to use, where you cannot use. Thank you. And don't worry if you don't understand the antibiogram or a policy much. We are just a phone call away. You can call us. Okay. Anybody will be very happy to help you to understand this better. So if you don't understand, it's good only. You can call us. Thank you so much.
What we will do now is, as I said, we will not have too many didactic lectures. Those who are all participating, can you raise your hands, please? Because we'll divide into two groups, then you go on to the stations. Can you raise your hands? Those who are there? Because online we will focus there. Please raise your hands and then I will, or otherwise those who are there, just say 1, 2, 1, 2, okay? 2 will go to one group and 1 will go to the other group. Can you start from here? 2. The other person there is not there. This side, what you ended with 2 or 1? 1, yeah. 2 you are. 1, 2. This side, who else is there? Anybody? 2, yeah. What I suggest, all ones go and meet Dr. Bernini, okay? And all 2s will meet Dr. Vandana. This side only, the back of you. Okay, just sit in the chairs, we'll start the session, okay? Each station is for 15 minutes and you switch. Fine? Right? The chairs are arranged. Camera ali takombartira. Takombani start maduvalli. For the, you have to take permission, no? Yeah, you have to take permission. And, yeah, it's fine. Hi, Doctor. How are you? When did you come?
I came yesterday.
Organizing this afternoon session. We can meet in the evening also, like faculty dinner will be there. Yeah.
Sit down. We'll start the session. Come friend. Vandana will start this time. Sit down, sit down. Come in the front. ಅಲ್ಲ ಹಾಗೆ ಅಲ್ಲ ಈ ಕಡೆಯಿಂದ
ಇಲ್ಲಿ ಬರ್ತದೆ.
ಈ ಕಡೆ ಇಲ್ಲಿ ಬನ್ನಿ 15 ಮಿನಿಟ್ಸ್ ಆದ್ಮೇಲೆ ಈ ಕಡೆ Ask them whether they can hear.
Culture methods of diagnosis have their own length of time.
Timing is keeping.
Duration by which you will get the results of culture's identification and sensitivity test in your experience. Your medicine, right? Medicine, 2 days minimum. Minimum 2 days. So is it sufficient for you to handle very severely ill patients where the dilemma is so much? If you get, when you don't get, when the patient is going down in sepsis and there is a clinical dilemma also, you are not able to identify what exactly is the
Can you ask if they
syndrome
can hear? They
and
can't
what
hear.
could be the most likely organism.
Vandana, you have to use them. Not for the online people. That's okay. Press it long. Speak softly a little bit. Yeah, it's fine.
Some indications, so you will correct the blood.
Something which is quite faster.
Ask them whether they can.
And coverage is very bigger. So the culture has a limitation. Only what can grow in the laboratory will be cultivated. Right? You know that E. coli, Klebsiella, Staphylococcus aureus, Pseudomonas, Candida, these are easily cultivated. Important fungi take longer time to grow. So generally the culture system in the laboratory
Then a little
goes
bit
for
more louder.
more. So they usually the practices in the microbiology laboratory is the cultures are held for a maximum of 3 days. Generally, okay? The routine practice, because there is no point in holding it for more in a larger set of patients. It doesn't work out it doesn't suit the laboratory practices. Unless you suspect a fungus separately, we do because it is a quite complex procedure. Each bacteria requires a certain nutrition. Fungi require a different nutrition. If you miss the golden period in the early phase to supply those nutrition to the clinical sample which might have bacteria or fungus, you lose that golden period and you won't get the diagnostics positive. Even though it was there. It is not due to the laboratory. It is the inherent mechanism of the performance of the diagnostics. Of course, if there is no clue given to the laboratory personnel that you are suspecting that, we lose time and we miss the chance of getting the pathogen. So what grows is the colonizer or a contamination or non-pathogen, which might be informed to you, and you are also clueless how to manage the patient because you got some result, you try to manage that syndrome, which may not be in the best interest of the patient. As a revolutionary mechanism, to get the results quite early, to cover a larger perspective, large time. In the last couple of years, maybe 5, 6, 7, last 10 years, the diagnostics has improvised to have a system of a syndromic panels. Syndromic multiplex PCR, which run on a polymerase chain reaction principle. Multiplex means multiple targets causing that syndromes are involved in that. Because it is a PCR, you get a rapid result. And here, the ease of use will make you get the results even fast. Would you be happy if you get a patient's meningitis results within 2 hours? Can you dream anything better than that? You have a patient in emergency department. You are hurrying up to do the lumbar puncture, administered antibiotics. You know it is a very serious emergency and the mortality is very high. And you will wait for the gram stain just to say no bacteria, sterile culture results. Then how are you going to manage further? So that is where you pump most of the antibiotics just in case I should not be missing this target, right? This is what all of you do. The outcome is antimicrobial resistance. That is a very, So, I will just show you examples of multiplex syndromic PCRs. You can keep this, you can pass it on. I'll give you some other papers, the other syndromes last. So the meningitis or encephalitis panel.
Vandana, can you focus on it? You have to show the chart for the people. Hold it this side. No, you explain it by holding this.
So here the panel, the multiplex PCR panel comprises of the targets which are commonly associated with that syndrome. So in this case, it is E. coli, Listeria monocytogenes, Streptococcus agalactiae, Haemophilus influenzae, Neisseria meningitidis, and Streptococcus pneumoniae among bacteria. And there are 7 viruses, including herpes simplex and varicella zoster, enterovirus, human parechovirus, which are the commonest causes of viral meningitis and encephalitis, including the yeast Cryptococcus neoformans. All in one, just in one. Okay. Provided the patient sample is optimally collected and not contaminated. Even if somebody has administered 1 dose of antibiotics before sending the patient to you, this PCR detects the DNA or RNA. It's not dependent on the live microorganisms, which will not grow if the patient is already on antibiotics. Okay. So same way we have pneumonia panel, lower respiratory, the pneumonia panel, which has several gram healthcare associated gram negative infection bacteria, then gram positive bacteria like Streptococcus pyogenes, agalactiae, pneumococcus and aureus, Staphylococcus aureus, atypical bacteria, Mycoplasma, chlamydia and Legionella. Okay, and then several respiratory viruses, adenovirus, corona, rhinovirus, influenza, MERS coronavirus, etc. All results in one. Okay. So same way we have joint infections where you struggle with the septic arthritis, you draw the synovial fluid, most of the times it is sterile. So we have a lot of fastidious microorganisms which are difficult to grow in the culture. So you run multiplex PCR on those samples and the results are available within an hour. So I will just take you through a few cases which we have had. So here is you can see one positive report. A case of pneumococcal meningitis.
ও বাবা আমার নেকটা জিওমেট্রিক হয়ে যাবে।
This is how
এইগুলো দেখিস না, যেগুলো দিয়েছি সেগুলো করে তাড়াতাড়ি খেতে যাবো, ওটা কারেকশন করবো, একটু তাড়াতাড়ি করো। একটু উল্টা পাল্টা দেখো না আনসার গুলো, ও পরে দেখবি এগুলো।
just have a look there.
সময় নষ্ট করতে পারলে আর কিছু চাই না চিটু, লেখ না তাড়াতাড়ি করে না এগুলো। আরে তোকে তো দিয়েছি এগুলো করতে, এগুলো কর তাড়াতাড়ি, সময় নষ্ট করছো কেন চিটু? তুমি তো জানো কি কি আছে, ও তো ভাবতে হবে না, তুমি চ্যাপ্টারটা বার করো। দেখেছো তুমি? তাড়াতাড়ি করো, রাফটা ইউজ করো, রাফটা ইউজ করে করো এগুলো।
Otherwise, what happens? The cultures will grow some colonizer.
So
What you start treating them with morphine. And the respiratory conditions will worsen. Then antibiotics
We'll focus on the laptop. Bunny. Done? Sit. Come, we'll start. This is the other blood culture section. Okay, so full compare. ಇದು ಲ್ಯಾಪ್ಟಾಪ್ ಮೇಲೆ ಫೋಕಸ್ ಮಾಡಿ Can you stand on the other side, Bunny? Yeah. Laptop. Sit. Doesn't matter. Sit, everybody sit. Sit. We are online. Where is your mic? Speak loudly. No, we have to tell. Deepthi, just check online, can they hear? When she speaks, we have to check. Start.
Is it audible?
Let them put. You start speaking, you start the session. If there is not audible, then come in the front.
All of you please sit down.
You sit here. We are all micro people then.
Aerobic and anaerobic. Here what we do when we collect a set of blood culture, are we collecting both aerobic and anaerobic? Actually we are collecting a true green cap bottle, that is the adult, both are aerobic, not the anaerobic. Now my next question is how much blood to be collected? 10 ml. Always you can collect a 10 ml. There should be some ranges. You can't exactly tell 10 ml. It's generally a 8 to 10 ml. For pediatrics, it's generally, anybody? 5. Again, you are very approximate. Means targeted. It at least 3 to 5 ml. Okay. Now, why does it matter if you collect less than 8 ml? Yield is very less. So if you collect less than 5 ml or less than 8 ml, the growth sensitivity of the yield will be very less. Please remember this. Why? You may not collect in the ward, but at least you see when they are collecting the blood culture. So if it is a case of infective endocarditis, how many blood cultures are required? Are you happy with the one set? No, 3 sets. So when to collect 3 sets? 1 hour after, like 1 hour apart. From same site? What are the different sites you prefer? Lower limb. You want to collect from lower limb. Anything else? Anyone wants to modify? Generally, we collect the blood culture for any bacteremia cases from 2 different sites. Correct? 2 bottles, 2 different sites. It's a right and the left antimicrobial way. If it's an infective endocarditis, you have to collect 3 sets over 2 hours but you can collect one from right, one from left, and after half an hour for another right or the left you can collect. If it's you are suspecting a CLABSI, then very good. One from the central line, one from the peripheral line, which should actually give positive first. The central line one, central line one, to tell it that the source is the catheter. Okay, it should be within more than 2 hours before the peripheral line. It should flag positive. Okay, to tell it as it's probably a catheter is the source of bacteria. So in the lab, what we do actually, if any clinical indications are there for the blood culture, we collect the bottle, receive the bottle either in a green or the yellow, then we load it in our automated blood culture system. Okay, we have Varma and the bacterial system. Then when the bacteria grows, it gives a flag positive. It indicates, you can see the green color. It will give a green color signal that one of the bottles have detected a growth. Then what we do, we take out those bottles and then we first test we do is the gram stain. After doing the gram stain, we give you an alert. If you have seen in your mobile, it comes, right? So we give you an alert. Why it is important for us to give you the gram stain? You might have started some empirical antibiotic. Now my second question is, when you should collect the blood? Before you start your empirical antibiotic or after you start? Before. Always before starting the antibiotic, you should collect the sample. Now you have started some antibiotics. Based on your gram stain, you may modify it. So we will give you whether it's a gram negative or gram positive. So which antibiotic you have started, you should see whether that antibiotic has a coverage for the particular bacteria. Then after that, that will be for us is the day 1. When the bottle flag give a positive signal, that is the day 1 for us. So don't expect that the day you have sent the blood culture to the lab, that is our day 1 for us. It is the day 1 is when the bottle flag positive. Okay. If they don't flag positive, we keep all the bottles till 5 days to tell it sterile. Okay. If it positives before the 5 days, that day we first do is the gram stain, that is our day 1. The gram stain report we generally give by within 1 hour after the bottle flag positive. Then what we do, we culture them. That will take another 24 hours to grow the bacteria in the culture medium. Sometimes if we see in the gram stain, single type of bacteria, we do directly AST from the bottle. If you see more than one type of bacteria, we don't do direct AST from the blood culture bottle. We let the bacteria grow, then we do the AST. Then the report will go to you through LIS after 48 hours. It may take hardly more 72 hours, not more than that. But if you do directly, then the second day only we will give you the AST and the ID. Okay? So don't jump after sending the blood culture on that day when my report will be ready. Okay? So it will be only ready when it is flag positive. We do the gram stain, we culture it, that will be our day 1. When it grows, that will be day 2. That day we will give you only the identification of the bacteria. Day 3 we release the AST. This part is clear? Okay. So what is the probable timeline? It's a preliminary gram stain within 30 minutes when the signal positive. First 24 hours we give the bacterial identification. Then the third day we give the AST. If it's a single type of bacteria, second day only we generally release the AST. Okay, this part is okay. Then we'll go to our case. Give you this. Dr. Archit, can you please take the... So one 60-year-old male patient with type 2 diabetes. Patient has a bilateral pyelonephritis. So in this case, what are samples do you think we should send to the microbiology to know the bacterial etiology? Patient is diabetic, diagnosed with pyelonephritis. So what are culture you should send? Urine culture and blood culture. So you have sent to us both urine and the blood. So we received 2 bottles of blood culture, that's a set of blood culture, and so we have received the urine culture. Next, so we saw when it flagged positive within 7 hours, and we saw this is gram-negative bacilli. So what could be the probable organisms? Do you think? So that based on your cumulative antibiotics you can start. Patient has a pyelonephritis. In gram stain we have alerted you with the gram negative. After 7 hours, the bottle bipped 7 hours, we did the gram stain. That means the bacterial load is very high. 7 hours it has signal positive after we receive the culture ball. So what could be the probable etiology? So that you will decide your antibiotic, right? Most common organism we isolate is the E. coli. Next, what we did is we did perform the culture and it grew second day, and the AST is there with you. Now all of you please see your AST. This is from the machine, the blood culture. You have seen. So you have panel of antibiotics. You can see some are resistant, some are sensitive. So which antibiotics you think from here can help in the treatment of this patient? Or you want us to release some more antibiotics? Or is it enough for you? It's showing sensitive or resistant? Sensitive. Okay. Do you want to correlate with some other culture in this case? Urine. Very good. So we have also cultured the urine, and urine also showing the same organism with the same AST. Okay. The count also is more than 10 to the power 5, the E. coli, and the AST also is the similar. So any bacteremia or any blood culture, whenever it be positive, please look for the source. So here it's a case of pyelonephritis. So you know where is the source now. So urine also, if you see, it's the same sensitivity pattern and the same organism has grown, which is more than in urine. Please remember the count of the bacteria is very important, because sometimes E. coli can present as just a colonizer. So when patient has symptoms of bacteremia along with the pyelonephritis and we have isolated the urine more than 10 to the power 5, and some urine, E. coli is the pathogen. It's isolated both from the blood and the urine. Okay. So what we do is in the lab, we correlate the blood AST with the urine AST, and we check that whether what is the source of bacteremia here. Suppose urine we get Klebsiella and our blood is E. coli. Can it possible? Possible? Many times, not in this case. Then urine is not the source. You have to look for some other source. Can be anything. Klebsiella, if patient has some respiratory symptoms, then the respiratory is the probable source. If the patient has the line could be the source. So always look for the source when any organism you are isolating from the blood or you are getting any blood culture positive. Okay? Thank you. Any doubt from your side?
It's different for every organism, every antibiotic.
Yeah.
So why isn't that also given in culture reports?
In which condition MIC helps you? Varma sir will tell you. Which conditions you require MIC? Any condition can you tell?
What if MIC is not released? Will it make a difference for you? If somebody releases only the sensitivity, not we don't release the MIC? Does it make a difference for how you treat? They will write no resistant anemia. Why do you need that? That they will put a comment. You have to read what they write. Dr. Vandana, they all write comments. Okay. You read that? Why do you need that? See, having intermediate is an uncommon phenomenon. You agree with that? Out of 100 cultures, how many will you find? So that's the NO comment. Correct? So why do you need MIC?
You want to see the graph.
Like maybe patient has a risk for nephrotoxicity or something, so you want to avoid, but that has...
That is not decided by toxicity first. That is not decided by the efficacy. The efficacy is decided by the site of infection. That's what she is trying to tell you. It is in the blood or in the urine. Understood? The blood, beta-lactams are always the drugs of choice. They are the best studied, the best stable in the blood. Yeah, best PKPD analyzed. Actually, we don't need it, but they release it because in some cases it happens.
Especially
So
in
only
infective endocarditis.
there, meningitis. There are specific conditions where it is really sensitive. Here, there, might be issues. It should not.
You can send. We are not getting actually anaerobic blood culture.
There's a separate bottle.
Separate bottle, orange color.
Orange color.
Orange color.
You have to ask for it. They are not keeping in the ward because usage is so less. It will
So
get
it is
expired.
bottle getting expired. It's not that we are inhibiting you not to send.
But even you will recommend it for infective endocarditis.
No, recommended is very straight. You send 4 bottles, out of which 1 should be anaerobic. Anaerobic bottle will also grow normal aerobics also. In fact, Pseudomonas has some issues here there, but otherwise it grows. Problem is when we try to introduce very few ascent, then they were expired. Logistic problem. You can always ask for it. Want somebody see then? Time is up. You come back and see. There's some more work.
Please give us.
So now what we will do is there are 3 stations to be grown. So again divided into 1, 2, 3, 1, 2, 3. Okay? Right? And then we will divide it. Yourself 1, 2, 3, 1, 2, 3. Start from inside. You start. 1, 2, 3, 1. Come, answer. You are 2 then. 3, 1, 2, 3, 1, 2, 3. You are 1, 2, 3. Shreya has to be 1 again. All 1s come here. All 1s to this station. All 1s. Okay, all 2s will go to 3M. Not combined, you're mixing separately only, no? You're doing separately. 2s will go here, 3s will go there. 15 minutes will switch. Okay? No, don't change the whole system now. I've already timed it. 15 minutes I'm giving you time and then you switch. Okay? All 3s will go to 3M, BD, sorry. 2s will go to 3M. Can you set? We'll start. Aditi, time. Make it 12 minutes. We'll start Mari next second. Mic. Get me the mic. ಅಲ್ಲ ಸ್ವಲ್ಪ ಈ ಕಡೆಯಿಂದ ಮಾಡಿ ಚಾರ್ಟ್ಸ್ ಎಲ್ಲ ತೋರಿಸ್ಬೇಕು ಇದೆಲ್ಲ ತೋರಿಸ್ತೀನಿ Can you put it in the group? Yes. Yeah. So this station is continuation of what we have been doing. We started off telling how hospital infections are and how they are studied. One of the major reasons why hospital infections are very difficult. Disinfectants are not used properly or they are not at all. We are looking at some some of the common things what we use in our hospital is similar across hospitals. Right? If you look at, there are simple concepts you need to understand, like I showed in my presentation, there is something called macroenvironment, okay, which happens around the patient, and that spreads infection to microenvironment, where you have all the salt, bed, mattress, stools are there which auto-infect the patient, right? You have so many things, right? You see our ICU, right? So what happens is, if you look at in a macro environment, there are a lot of beds, either the nurses, doctors, the cross-contaminating, the housekeeping. These are the most contaminated area, the washrooms, where all stools, urine, everything, because that is full of bacteria. All the resistant bacteria are there and they cross-contaminate. Right? Because we go there, wash hands, come back. So if this system is not broken, the infections either will process like this or uninfected bed will get contaminated. So once it breaks, this is bad to disinfect. Right? Okay? This is what happens in many ICUs, including ours. See, once patient is discharged, right? Then before the new patient comes, they are supposed to disinfect. Right? If the disinfection is not adequately done like this, the efficacy is not good, or you don't give the time. You keep seeing medicine with shift. Because they don't give the housekeeping time to shift. The patient is very sick, why are you not shifting? Remember those dialogues? Then there is under. So by the time the patient reaches here, this environment is already infected. And within 3 days, I showed you in our study, patient is colonized. You don't shift the hospital, you get a bad. You understand? That's why disinfection is controlled. Right? So we are trying to. So you need to understand the basic terminology of it. One is antiseptics, what are antiseptics? Any solutions or issues which we use for living organisms. Okay? Disinfectants are more powerful, but we use it for non-living organisms. Really? Right? Examples will be alcohol. These are all the resources. These are all the antiseptics. So the Aldrop, you know, this has chloride 0.5% and 70% alcohol. Right? And these are to be used on the skin. This is iodine based, we have fluorexidine based. For when you say skin, you use 2% or 4% in some countries, fluorexidine. Whereas for hand rub, it will be 0.5% plus alcohol. Okay, because they can't use too high for protein. Agree? Then there is disinfection. Disinfection are more powerful because we use it for non-living things. Right? These are all the disinfectants what we use here. One of the most commonest we use is Vandana. Vandana is the one which we use for all high-risk areas. It has 3-4 chemicals which will not only kill the bacteria but also act as surfactant, removes it from the surface. So it has a lot of, but the cost will be higher. Right? The challenge is we have to dilute it. We have to train all the housekeeping proper dilution. It is like this medicine PG orders. A lot of mistakes will be there when we audit. So we keep training them. Okay? So that is how it is. Then there is something called cleaning. Cleaning is a very essential part. See, these both will not work if cleaning is not done properly. Because whenever there is dirt, no antiseptic or disinfectant will work. There is a lot of importance to clean. So remove the physical dirt. Okay? Decontamination is similar process in disinfection where the items are cleaned, basically OT items, kidney trays. So these are the terminologies you need to understand. There is no proper cleaning, we don't do that. Like a story this time around God, just go to an ICU ward, take alternate water, and then rub across one patient, see how much dirt will be there. So that is a very important step when you are doing NG, SIT tabs. You don't clean properly, you are actually introducing. In fact, I remember 4-5 years, I proven that our medicine PG costs and SCP. PG costs, patient handicap. That is documented. So that's how important antiseptics is. Because cleaning is this. Make sure you clean. Because most people sweat a lot and climate is like that. And they need to clean. Understand, right? Cleaning is very essential. Then what are the important principles? Whenever you do disinfectants, do cleaning every day, but we can't do it regularly. Once patient is discharged, then we have something terminal. Make it terminal all time, not till the time. So the seminar cleaning can be service cleaning, like all the services we do, or floor cleaning, for floors, for ICU different disinfectant, for walls we use and then toilet cleaning. The end of cleaning is we never start cleaning from toilet and surface. We always start from most non-infected area to infected area. Many times if you go and observe, because the patient is there just cleaning the toilet, then they go to the wards. It's the worst case scenario. Breaking all your Klebsiellas and the gut. That's where it comes to your line. Understand? So we keep monitoring it and do that, right? Similarly, if you want to clean an ICU ward, we tell them always do this and then go in this order. The least infected should be cleaned first. Okay? Right? And we always train our wear proper PPE. Very, very important. I tell you what happened. Right? Because they can get damage to the skin, lungs, they can inhale and can cough, right? Some people can long term can develop ILDs also. These are all been documented in our hospital, right? Right. Now, there's something called a 3-bucket system. I'm sure all of you have seen it, right? So you want to explain on this?
In this, we will take first bucket, detergent, disinfectant, detergent, disinfectant and water. But in our hospital, we are using Infectious and BKC for the ward, right? So detergent and disinfectant all together. So we are using only 2 buckets. 2 buckets they are taking the water. And
yeah, so if you look at this, how this happens is, this idea is, we don't want this dirty water mixing with it. I told you, right, something similar to cleaning. If there is a lot of dirt, all this disinfectants get utilized. So that's why dirty water should not be there. Okay, the whole idea is, you use this bucket which is chemical, clean it, and then come and put it into the dirty water. And then put it in the fresh water, then use this. You got the point? And this is a capture where you just push the knob, all the water gets drained, excess water, so that there is no excess of water on the fresh. It is a very simple technology, has a lot of impact. As sister is rightly saying, Vircon we use for high-end disinfectant for the ICU areas because we use across hospital, cost will be too much, right? And this we use it for the wards. If suppose there is an outbreak situation, then we switch to that area. Like one case we have a C-dep there. If something happens in the ward, we switch to that ward Vircon. You got the point? So immediately we are notified and we act out. So all that HICC does. Then why high level disinfectant, broad spectrum, where they kill lot more spores. Spores are the most difficult to kill. Most bacteria die, viruses die, right? The ward we don't need that high end because most Western bugs are in the ICUs or high risk areas. Like the transplant areas we use it. So if we are having a virus, there are 2 types of viruses, right? Enveloped and non-enveloped. Which are difficult to kill? Non-envelope, because most disinfectants knock off the envelope. If there is no envelope, it is difficult to understand. One of the common viruses which stay in the ward, in the hospital is norovirus. Very difficult to knock it off. That's when disinfection protocols have to change the moment we have diarrhea patient unexplained. Right? Remember we are discussing all this. So we change our protocols based on it. The last one is toxicity. This is an incident which has happened in emergency department a few months back. So how serious things can disinfectants be? One of the housekeeping accidentally mixed the alcohol and acidic cleaner with the 5% hypochlorite. funny. I'm sure you've seen all these bottles. We get it like this. We discard it within 1 week. There are some within 1 day because of processing costs. Accidentally, huge food stain. All of yellow area was covered. All of yellow area was covered by fumes. About 3-4 times got admitted because they incurred bronchitis. Right? And we had to immediately go act on it, and then most of them recovered fortunately. So that is the importance of knowing about disinfectants, because that can cause serious problems. So what we have done is we have done a study of why this has happened, and now we are training the people. Not only that, we found out how human behavior can change. Same thing, we are making sure that these two are not physically same place. That bottom line is they should never be physical. It is like, again, analogy of medicine, which is most rounds, they don't like to come if they are far off. Right? Suppose there is a concentration deeper, very few medicine pages will come. Correct? Because they are far off from there. So that is a human mentality. So what we have done now is we separated them physically very far off. Right? So disinfectants play a huge role, unfortunately not well understood by the most of the people who actually treat infections. Okay? Right? Thank you. Thank you. Now we move to the next session. And we'll switch that to go that side and then we come.
These are the devices, safety devices, and then you can use safety devices. So this is a major thing.
That batch has to come this side.
Yeah.
Come this side.
Thank you.
3 come.
Yes. Take the one side. Sorry, my
Come, sit down. If you have 10 minutes, you remind me.
Good afternoon, everyone. So we are going to see the prophylaxis treatment for extraluminal source of contamination and intraluminal source of contamination. As you were seeing during the theory session, so I was pointing it out on hub care. So as per the research that we had done, only 30% of the nursing pool adheres to this hub care, and there is no uniformity in the practice. And again, asking someone to stand near a patient and say 1, 2, 3, 4, up for 15 count. Okay, while at least during scrub they might do, but when we are going to ask them to wait for the alcohol to dry, again 15 seconds they have to do, it is impossible. And because the call for the profession is also so strong that the nurses keep, you know how nurses keep running in the hospital. So we have, the guidelines also says if you are going to the active disinfection, it should be uniform across the hospital, and if not, adapt to passive disinfection, where you are going to take up a Euros cap. Okay, if you look into this cap, it is, the color is vibrant, okay, which indicates visibility, so that you can easily audit the patient also whether the coat is closed or not. And if you're going to see why I should use this, I may, if I'm going to use a Euros cap, I'm not, it's not required for me to do a scrub the hub technique, and within 1 minute, okay, it becomes sterile and gets ready for the next use. Suppose I'm not going to use the coat for next 7 days, and I have covered it with the Euros cap, the shelf life is for 7 days. On the 7th day when I come and remove, it is still sterile. Okay, and it is meant only for needleless connectors. Please do not use it for the female doers. The reason being, why you shouldn't use this, it is being impregnated with 70% of isopropyl alcohol. It will not fit into this, for example, your 3-day stock clock or your IV line where they put a white cap. Instead of that, in one of the hospitals that they've done this, they've fitted into it, forcefully fitted, and what has happened is this sponge has entered into the line. Nurses have not noticed it and they have flushed the line. It has caused an emboli, and especially it was a PICC line, and they had to remove the PICC line because of this. So this is meant only for needless connectors, and this is a single-use device. The reason being, it has been impregnated with 70% of isopropyl alcohol. The affinity of the alcohol is to evaporate. When I'm going to take this and keep it on a table and I'm going to flush a line with the medication, flush the line, when I would have accidentally touched the hub, and if I'm going to use the same, it is not going to be effective. So it is meant to, each time you access the port, it should be different cap each time you're going to access, and it is effective again 99.9% of all of the 6 commonly known microorganisms that is causing CLABSI, including 2 strands of Candida, that is Candida albicans and Candida glabrata. Okay. I think I pronounced it correctly. Glabrata. Okay. So when I talk about CHG, you know the action of CHG is antimicrobial. Since you're putting this CHG pad will cover the insertion site and the suture site, which becomes the most important place where the microorganisms colonize because of the normal flora of the skin. Okay, even if you're going to clean your skin or if you're going to prep the skin with your skin preps, this is going to be effective only for 6 or 8 hours. After that, the skin will start sweating and there will be a regeneration of microorganisms. In that case, if you're going to use CHG, it prevents the colonization as it is antimicrobial. And the other thing is, as per the guidelines, if you're going to use the CHG, it can stay for 7 weeks. Either ways, if you're going to use sterile gauze transparent dressing, this sterile gauze transparent dressing, as gauze is not an absorbent. Okay, each time there's an exudate or the blood or the fluid leaks, it has to be removed, or every 2 days once it has to be changed. So the frequency of dressing increasing, exposing the insertion site with external environment, again your patient is again at a risk of developing a CLABSI. So going with CHG, it will protect your patient. And if you look into the design of the dressing, okay, it has an antimicrobial protection, that is CHG. It has an edge border, so that it prevents the edge lift. If you step into the ICU, most of the time the dressing will be hanging like this, and when you point out, they will just pull it up and do a patchwork with the microphone, which is not an evidence-based practice, or it is not, the practice should not be encouraged. So you have to ask them to use dressings which has a good affinity to the edge. Okay, and it has a larger securement tape where it can easily promote consistent application, and this notch sometimes helps when the patient, when the nurses use this as a secondary looping technique. So this prevents the device-related skin injury, because whenever you loop it puts a lot of pressure on the particular part of the skin. This also can lead to device-related skin injury. And whenever you're applying, you should ask them not to stretch. Okay, why we got into this practice is we started using AEDs, and for example your dynaplaster. Your dynaplaster is a compression tape. So there, where you are going to use it when you're removing a sheath where there is a oozing of blood, you're going to arrest it with giving a digital pressure. Over that you're going to put a dynaplaster where it acts as a compression tape. When this was shifted as a securement device, so people started using the same technique of stretching. Okay, but when we started, as the awareness improved, we asked them to use transparent dressing to identify early signs of phlebitis, then this dressing came into practice. So the old practice they're following is they again stretch and apply this dressing. The assumption is if they stretch, it is going to stick properly, but they are wrong, because the bond between the adhesive will break. And it will not stick properly, and they could be easy edge cupping. Second thing is, as they stretch and apply, the skin also will stretch. And over that you're going to put a dressing which has an adhesive. As the days goes, there would be a tension blister that has been forming, which looks similar to that of your rashes. The reason is the skin is trying to come back to its normal because of the elasticity present, but this adhesive is not allowing the skin to come back to its normal. So if you're removing the dressing, obviously this blisters will break and there will be a skin peel, which they will be marking it as MRC. To prevent it, you have to just remove it from the dressing. Okay, can you come here? Switch it please. Come. You have to just hold it like this as it is. Okay, I'm going on a hairy part. Okay, imagine. Okay, imagine there's a big line here. Actually, it should go there because of the shot I just showed you. I'm just holding it this way. I apply. I give even pressure. I ensure there's no any air bubbles. And when I just loop it, the loop is popping out, and it makes my removal easy. When I remove itself, I'm going to support the edges so there is no edge left. Okay, and this is in the lock-in key model where the movements can freely flow. Okay, and since it is a sterile technique, we are given the easy strips here so that you don't fight with your glove, and this is how it has to be there. And when you're going to put the data sheet, it can come on the sides so that I don't involve the extra skin of the patient. Okay, so I have applied, and this is how it looks. Here comes the insertion site, and the suture site also of the delta wing will easily be fitted into this. So when I'm going to remove, okay, so what I have to do, current practice, what the nurses do is they soak the dressing with the hand rub. Okay, and they're so generous with that, they soak it, and even there will be stains on the bedsheet. Okay, but if you look into your hand rub, it has alcohol, which is an irritant to the vein, and it can cause chemical phlebitis. So to prevent that, what they can do is they can just go with the flow of the air. Okay, it's something if you go to the parlor, they put a hot wax on that, they put one cloth in the opposite direction of the air, they remove, so that at that part of the body the hair is removed. That technique we are not going to follow. Here we are following a traction method. I just identify how the hairs are flowing. So I go along with the flow of the hair. As I do it, okay, there's good hair. There's no pain. Let me see how he reacts. If I go in the opposite direction, it is going to pain and it is stuck here. So to prevent that, first of all, I have to remove all the extra securements along with the flow of the hair. Then I start stretching. So here what I'm ideally doing is I am breaking the bond between the adhesive so that no need to apply alcohol or a hand rub and soak it. So now it was easy for me to remove because I have applied and removed it immediately. The challenge the nurses might find during the removal after 7 days is this will adhere very tightly on the delta wing. At that point of time, they can use, anyways you're having some flush, which you get. Those flush, they can put 1 or 2 drops of the flush can be put, it gets diluted. Then again, in the consistency of a bubble gum, they can just pull, it comes off. So they should only be trained on the application, otherwise this can even lead to MRC. Okay, so which is again a nursing quality indicator, now it is being captured. Any doubt? This is again breathable material which allows the sweat to evaporate.
This name is CHG 1650.
No,
Material you are asking.
This poly.
This is the transparent dressing. That material name I will.
That is CHG. That is CHG patch.
Cornerstone gel.
Okay, that's a CHG patch where you have to just stretch it so that it becomes easy for the nurses to remove. Otherwise, what will happen is they will be pulling it very hard. No, it is a tetrapolymer. It's a tetrapolymer, it's not a plastic.
Thank you.
Thank you.
Shall we start? So, you have seen about that. Just see how big is the risk. and what is the risk is the leadership NS. So we just see some stats and data where this is a CDC, is a Center for Disease Control and Prevention, estimates 385,000 of sharp injuries annually among healthcare professionals, significant of which NSs are, that means around 1,000 injuries per day in USA. But if you see in Indian data, in a 100-bedded hospital, every year there is an estimate of 30 NS. So you can calculate with the, for Kasturba hospital it could be around 2,000 bedded accordingly. But however, if you see in India, that means estimate is less than 2,70,000 compared to that of America's 3,85,000. What would be the reason?
So the guideline says that you are going to adapt with your active disinfection.
Underreported, exactly. So in India it is too much underreporting, so we don't get it exactly. And equal to injuries also accident. In a study they found that 57% of hands of nurses had some cuts, wounds, bruises. If you see your nurses, sometimes I don't know, other ways outside, they take the hand gloves in the tray for cannulation, but they don't wear it. Okay. So that is because if they get contaminated, exposed to contaminated blood, what would happen? They would be affected by hepatitis B virus, hepatitis C, and HIV. Hepatitis B is around 2 million per year. Hepatitis C is around 1 million, and HIV is less. And if you see, hepatitis C and hepatitis B also more dangerous compared to that of HIV. So who gets impacted in this process? Epinet is a center where it collects data. They have done their data from 4 Indian hospitals located at 5 major cities. Over 2 years suggested nurses are the highest risk of MS. So 55% nurses, 20% of housekeeping, and however 10% were physicians also. And out of 380 healthcare workers from a major hospital in Mumbai, 4 reported MS, and more than 70% of injuries were experienced by nurses and housekeeping. Again, 10 to 11% were physicians. And in national surveillance system of healthcare workers USA, more than 70% of blood and body fluid exposure are experienced by nurses and physicians. And the sample size was 30,927. You can see 42% of nurses and physicians were 30%. So equally affecting the physicians also. And likewise, statement in a year, this is a data which says that in a year a healthcare worker who is joined the profession and retires in that out of 168.3% have an NSA during their career. Okay, females experience more NSA. What would be the reason?
When it comes to CHG,
yeah, it is not any gender bias, but more of the females are healthcare workers. So in from nurses, doctors, so they are females are leading. So nurses, if you see, 51% and physicians are 40%. And NSA, what stage you get at NSA? 82% of the NSA happen during the use of the shock or just immediately after the use, just before the disposal. What would you use? Used? Yes. Recapping is major concern. So if you see during the time of use was 44%. And after use, before disposal is 38%. Which type of devices are getting NSA more? If you see needle on the disposable syringes, it was around 41.56%. Again, the reason could be the recapping of the syringes cap. Type of device involved in percutaneous injuries, 30% is due to the hypodermic needles attached to the syringe again. And even if you see some nurses, when they give insulin to the patient, admitted patient, they try to recap that insulin syringe also. That also is a major contributor here. Where a study of critical care teaching hospital in North India occurrence needle study showed that in emergencies and ICU is 48%, needle injury, general ward is 30%, and others is 20%. So 22%. But according to National Surveillance System of Healthcare Data, inpatient data and OT are high risk. Implant is 55% and OT is 29%. However, in emergencies, less. So now again just to elaborate a little bit, sir. Majorly What has happened, sir, like in infection control, whatever best products are using, the world class product, that I would like to say that BD, this is the world class product, mostly used in more than 150, 60 countries. But if there is no basic hand hygiene properly done, this product will not help also. Using a best product also will be not of use. So hand hygiene is the basic hygiene is very, very important. And however, they have showed that closed system is, this is the closed system, this is the open system. Closed system scores over the open system. What could be the reason? The reason is that this cap. They have seen in a study that this cap is a major leading cause for infection. What could be the reason? Again, yeah, sometimes it's on the tray, sometimes it's on the table, sometimes it's on the pocket. And if you see the design of this cap, it cannot be cleaned and reused. So, and this at any given point it will be closed, so it will stop entering the infections. But however, if they don't use it properly, like if they don't scrub it properly and use it, again the infection on the surface would be entering. So for example, if I want to give a flush, again if I don't scrub this, allow it for air dry, then if I directly use it, whatever microbes inside, it will go inside. So that is the reason they say you use proper, again, products. And again, as a manufacturer point of view, how we are going to support in this NSA prevention. This is called needle-free connectors. You don't require needle for this. And when you come for flush, when they are trying to do a manual flush, what they have to do? They have to use a needle. They have to prick the saline and they have to pull it. But here you don't require a needle. Again, you are avoiding one chance of getting the NSI. And medication error. So if you see normal manual flushing, they pull saline, they keep, they pull medicine and keep, and sometimes if they get distracted and labeling is crossed by mistake, then there will be chances of medication error. But here it is clearly labeled and pre-filled. So this will avoid your medication error also. And we also have this Eclipse needles, where this is an active safety device. Whenever you put it to a syringe, use a syringe, then afterwards you have to lock it. So this will help you to not recap it, directly use an activated active device. And we also have safety cannulas, that's what Manipal Pro Safety. What is the best part in this is, once the cannula is pulled, when the stillet is pulled, if you pull the stillet, there are some pores which will absorb the blood flash also, and there will be no NSR, it comes with the cap. You can touch and see. Yeah. So again, there is a chance where you avoid a NSI. How this is how we have engineered devices which will help the healthcare workers for their safety. You can try and use. I'll give you syringe also. You can attach to the syringe and see, and you can clap this. Yes, for example, so if you're using a syringe, use it and you lock. Yes, easy. So this way, we are trying from our end that the healthcare worker will get their safety and reduce the NSC. And these are the 10 rights, sir, for basically for the medication right, and a medication like right patient medication, right formulation, right equipment, right dose, right time, right route, right documentation, right storage, and right disposal. That's it, sir, from ours. Thank you, sir. And one more this thing is that we are trying to introduce this newer type of this thing that is called stat lock, where in central lines when they do, they have to suture it. But here you don't require to suture it. You have to put the plaster here and put the 3 lumens and you can lock it. So again there is a chance that you reduce the needle stick, because again during suturing there is a needle being used again. So these are, we are coming up with how we can prevent NSI for the healthcare workers as well as the patients. Thank you. Thank you.
बेटे और कहीं और अब हाँ
लेकिन उधर ही रहेगा।
हाँ
Come back 10 minutes, then we'll take a break after that quiz. Please all of you join back. Come. After that, in break time, you can have a look at the microscopes. They're around. And see. No, this one is fine. Better than it. Online people are okay? Online? One short session on antimicrobial stewardship, then we'll have a tea break short and then quiz. Fine? Right? I hope that stations were interesting, right? Online, I don't know. I request all the online people to give their feedback. Probably next year we will try to be more innovative, right? So please come back, all of you, those who are at the stations. Right, and actually disinfection section should have a post test, which we didn't do. We will put up probably just before the quiz, the QR code. Yeah. So how many of you have heard the word antimicrobial stewardship? All of you have heard? Right? All of you have heard. Why do you think it is required? For me, it's actually the word is, it's not good. It looks very strict word, right? Stewardship and all. So what do you think is the importance of knowing? Why do you think that whole system came up? What is the logic behind it? Any idea? Anybody wants to try that? Is it to reduce antimicrobial resistance? Is it to reduce AMR or not? One of the aim, right? So, but that is the biggest challenge. The problem is, AMR is a very complicated system. Like, I'm sure this happens in India also. This is a picture from Colombia where people are selling on the road antibiotics. You can buy analgesic, antibiotic on the road. You pay the money and just buy it. Right? That is the situation in the world we are living in. Right? So, assuming that by doing stewardship will reduce AMR is a myth. Right? To a certain extent, yes. Understood, right? Because antimicrobial resistance is a very complex problem where one health concept has to be understood, where human health Animal health and environment has to be understood. So I'm sure you heard about One Health. For the PGs, this could be a short note for you, right? Because it encompasses lot of systems in place. Agreed? So it is important to understand when you design your antimicrobial resistance, the primary focus should be more on patient safety, the toxicity, cost, drug interactions, etc. Agreed? AMR will come, but just by doing stewardship will not help. Like morning we had discussion whether to give ceftriaxone, CP, it hardly matters now, right? We have already crossed that line. So what's the definition? Very simple. It's a coherent actions to promote responsible use of antibiotics. That's it. Very simple definition by WHO. Agreed? Basically we use the antibiotics coherently and responsibly. There are multiple aims, as I told you, like using antibiotics only when needed, selecting appropriate drug and use. Some of these are difficult to do it in day-to-day practice, right? I feel most easily done is limiting the adverse events and unnecessary cost. I think that probably is easily doable. All it needs is extra few minutes during your rounds. Then if you look at how patient management goes for infectious disease, the first thing when a patient comes to you, what do you want to do? We want to do a syndromic management. Dr. Bernini, Vandana were telling, right? How panels are also coming based on syndrome. Somebody comes with altered sensorium, fever, headache, it's encephalitis. That's the first step. After that, before the cultures come, you start therapy, what is called empirical. That is where your antibiotic policy, which wonderfully Dr. Vandana has taken, how it helps your antibiogram and make it antibiotic policy, right? Then comes microbiology releasing. We have one of the best micro labs in India. So we can do diagnostic. They don't release every report like Bernini was explaining, right? Otherwise they think, okay, the drug with maximum sensitivity, I will use it, or lowest MIC. It doesn't work like that. Agreed? Then we do a targeted therapy. Once we get a culture, we step down. And then finally individualize. Somebody has a CKD, we dose modify. Somebody has hepatic failure, we use a different drug, etc. Most important thing is, according to me, stopping the antibiotics early. Starting is very challenging. Being a clinician, I know. So if you can stop it early, every patient won't require 2 weeks, right? The other important concept of antimicrobial stewardship is aware classification. What is aware? All the antibiotics and microbials have divided into 3 groups. This is by WHO: access, watch, and reserve. We allow access, we sort of monitor the watch, but reserve the reserve drugs. Reserve drugs are basically carbapenems, colistins, your linezolates, all the newer antibiotics. Agreed? So, but this for an individual patient it is difficult. This is basically an hospital to monitor how we are using each section. If a hospital using lot of reserve drugs, indirectly tells you that your stewardship is not working, indirectly telling there's lot of AMR. That's why the doctors are forced to use. So just like I was telling in the disinfection and the other sections, if I can reduce my infection rates, automatically the antibiotic usage also will come down, right? They're all interlinked. So what are the strategies for AMS? There are 2 strategies. There are many, but these are the 2 important ones. Prospective audit and feedback. Other one is formulary restriction and pre-authorization. Each one have their own advantages, disadvantages. When you say prospective audit feedback is a real time. Patient comes, somebody starts an antibiotic, culture comes, and the stewardship team will analyze the culture and communicate to the cleaning team, this drug is not required. Suppose like in that case, Dr. Bernini, E. coli is growing, why do you want teicoplanin and vancomycin there? You don't need it. So we communicate. Then we leave the decision to clinician, because idea is in IPC and AMS, if you confront, the story ends there. There's no point fighting, right? We are always peace brokers. If somebody is fighting with us, I don't fight with them back, we move on to the next doctor. Because idea is systems have to change. We try to make friends, but they don't like it because we had a tough times 10 years back. Now I'm senior, so life is a little bit easier, right? So you connect bridges and tell them. This is problem with this system, this strategy is it works really well, but it's labor intensive. It takes a lot of time. Every day mornings I sit and do email of this only, right? Second thing is formulary restriction. Like all the reserve antibiotics which are recently introduced, what we said is, we allow them to use for first 24 hours. After that, only if there is an indication we release. Like Cefta-Avi, we do that. Okay? We have a WhatsApp group. Moment somebody uses, it comes to us. Then we just review and I say approved for 3 days, approved for 2 days, or not approved. Then all fighting hell loose. I wrote, why not given? But slowly people understand now. Right? So each one has their own advantages, disadvantages. What I have done in our hospital is walked a middle path and try to do both, but in a milder version. So what we do is, if somebody is using lot of antibiotic long duration, we send an email like this to your left of you, saying that, respected sir, this drug is 13 days, can you think of stopping it? And then we give a feedback form and they fill it up. Most people are okay, they may not reply, but most of them stop. Our rates also, you can see overall it is coming down. Then as I say, reserve antibiotic, we have an WhatsApp group where we put the patient details and the PGs communicate, and we try to stop it whenever it is not required, or we authorize. Most of the time I approve it, right? We don't want, but this itself, there is a thought block in clinicians. Okay, somebody is observing, I will not unnecessarily. Otherwise Everybody will get Cefta-Avi without even indication. Somebody has cellulitis also will get it, which is absolutely no indication. The second area where respiratory tract infections are the most commonest area of misuse of antibiotics. So we started a program 3-4 years back where we started informing ENT, PTCD and medicine. These 3 departments treat respiratory infections, right? So we created simple scoring system, tried to put in the desktops also showing whenever they see, and then say that don't use antibiotic. If you are using, use either comoxiclav, because they were using so many other drugs. So the rates have come down. Then the other important thing is the metrics. We are doing lot of intervention. Is it really making a difference? There are different metrics. One is DOT, duration of therapy, days of therapy. Then DDD, defined daily dose, and days of antibiotic spectrum coverage, DASAC what we call. Right? The last one has not been very well validated. It's a recent one. But DOT is basically you're looking at how many days patient has taken the antibiotic. We don't look at what is the dose, what is etc. Whereas DDD is more of how much grams, like how many grams of meropenem did the patient use. So one of the biggest advantage of DDD is I can measure it for my whole hospital, but I want to use it for individual patient, it is not going to help. Right? So suppose I want to say state of Karnataka, what is the DDD of meropenem? It gives me a rough idea. Right? DOT is more specific with respect to the patient. Each one has their own advantages, disadvantages. Suppose somebody has a renal failure, I use only 2 grams, 1 gram BD. DOT is correct, but DD says you're using less. Actually, we are not using less. You got the point? So there are advantages and disadvantages. DASAC adds that little bit advantage because it gives the antibiotic spectrum. See, for example, we are equating meropenem and somebody has amoxicillin, right, gram wise. But we know meropenem has far more broader spectrum, right? So its ability to cause antimicrobial resistance is far higher. So that adds that, but it's not full validated. We have done some work on it. So, but you need to know that. Then two more important things. This was the patient who was admitted about a year back for cerebral vascular accident and got intubated. And then he developed VAP, ventilator associated pneumonia, due to carbapenem resistant Klebsiella pneumoniae, right? Can you guess what is his total bill? I'll tell you the total bill, you tell me what is the cost of treating with the antibiotics. The total bill came to 5,14,000 roughly. Of that bill, how much was his antibiotic bill? Take a guess. Just take a guess. It's okay. You can tell. The patient got discharged. I think he's okay now. How much after 5,14,000? How much did the patient pay? Antibiotics alone. When I say antibiotic, I'll tell you the other things what we add up. Take a guess. 3 lakhs. Yeah, roughly like that. 3 lakhs to 19,000. You understand how much impact the highs have, no? Right? That's why we are focusing more on it. When I say antibiotic, I am not looking at only the cost of antibiotics. The amount of, you have seen that tegaderm being used. Why are we using it? To prevent something, right? All this is added in the cost. These diluent we use, the vehicle what we use for antibiotic, everything we calculate and see how much impact it has. I can't say, okay, this thing is, got the point? So that's very important for us to know. Second important thing is toxicity. Unnecessary antibiotics usually cause. This girl came from Bangalore. She was working in a small firm there. She had cough and fever. I don't know why. They bombarded 2-3 antibiotics and she developed very bad dress. And she spent 6 lakhs for a patient who never deserved an antibiotic. 6 lakhs was a bill. Okay. So she had a very bad toxicity to ceftriaxone. I don't know why they gave, somebody came with just cough and cold. I think everybody gets that in major cities, like 1 injection and 1 tablet. So these are the problems. So what we have done is, to make all the clinicians aware, we created a system in the hospital where we have informed all the antibiotics, like what are the worst antibiotics we use? Carbapenem resistant bacteria, right? Your Klebsiella, Acinetobacter, CRKPs, crabs, etc. So we created a table to give the doctors, apart from just giving antibiogram and antibiotic policy, we gave cost analysis, which is in our intranet. See, for example, if you have ventilator's pneumonia due to crab, how much is the cost, what drug you use? So unnecessarily people were using alternative drugs, which is so costly. Right? See, 14,000, this all per day. Just imagine 10 days means 1.4 lakhs. So you have a better alternative. Similarly for everything. Like we found a lot of fosfomycin being used. Fosfomycin is the most costliest with the dose we use. So we started this system and encouraging people to use first line, which is more efficacious and much cheaper. Right? So these are some things which from stewardship point of view we do. It's not about only reducing AMR. So ultimately, to end my discussion, infection prevention and AMS is just for patient safety and also probably healthcare professional safety. That's our aim. Right? Unfortunately, the focus is not on more on that. Focus is so much on therapeutics. Right? Which antibiotic, which mutation, that, which diagnostic test. Way our motto is always, why are you reaching that point? If you can prevent it, that discussion never happens. Right? That is our goal. Right? So again, it's all teeth. You need to be motivated because this is no rocket science and recognition is very minimal in all this. Right? That's why most infection control conferences, etc., hardly doctors attend. It's all nurses and housekeeping attend, right? And most of the time, infection control topics are very few in major national conferences. Correct or no? I'm talking about ID. But that's an unfortunate thing. Anyhow, thank you very much. I hope you enjoyed the whole session of infection control. We try to be as practical and tell what we are doing. As I said, I always feel we should adapt to local problems rather than pulling out information from somewhere and look at it, because each hospital is unique, each problems are different, right? If there are any questions from your side, anything about antimicrobial resistance or any of these stations, like if you feel anything else we missed out, probably next year we can add it, right? If you feel any sections of this preventive science we missed, we are more than happy to introduce it. Any questions? Nothing? Online, any questions? Nothing? Okay, fine, right. So after this, I think we'll have a short tea break and then come back for the quiz. So before that, I will request Dr. Nitin to come. Nitin? Dr. Nitin? Is there? Nitin? And I request Dr. Vandana and Barnini to come here. So we'll request them all three to come. I'm sure you all liked their stations, right? Okay, very precise, very knowledgeable, right? We have a fantastic micro team. We are all blessed, right? I request Dr. Nitin to hand over a memento to Dr. Vandana. Dr. Vandana, on the stage, please. That's for Dr. Vandana, right? Let her come. Dr. Barnini, come. Big round of applause. Wonderful work. Thank you. I request Dr. Barnini on the stage to take a memento. Barnini is our secretary, does a lot of work behind the curtain. Thank you, everybody. So we'll join in the tea, and 10 minutes sharp we'll be back. Yeah, one more for me. I don't. It is self-goal, I always say. Short tea break, and we are back for quiz. Right? Shivdas, stage is yours.